Instead of a liter, use 500 milliliters as your default fluid bolus for the elderly, and add if necessary. This will decrease the risk of overloading a patient with underlying heart failure. If you really can't explain the cause of syncope, consider looking into cardiac enzymes. Some heart attacks are silent. A patient with known atrial fibrillation whose rhythm has suddenly turned regular may have developed a complete heart block. A patient with hyperacute T waves and chest pain is very likely to have an acute coronary syndrome. Remember the no-brainer indications for getting a brain CT for a patient complaining of vertigo. Some ear pains kill. Rule out mastoiditis in all earache patients. A bad primary survey before sending the patient for a trauma scan can be extremely risky. If in doubt about a pneumothorax, there's nothing wrong with getting a portable chest X-ray before sending the patient off to radiology. Headache associated with lateralizing symptoms can be sign of a sinister pathology. If limb ischemia is a differential diagnosis, get a CT angiogram out of hours. The presence of pulsation on Doppler ultrasound doesn't exclude arterial occlusion. Compare Doppler wave strengths bilaterally. A discrepancy here is a reliable clue to the presence of occlusion. A 5,000-unit bolus of unfractioned heparin followed by a calculated infusion is what the vascular specialists usually recommend.